Hi, this is Anthony Effinger. I'm here on the Think Neuro podcast. I'm speaking with Dr. Garni Barkadarian. He's a neurosurgeon and co-director of the Pituitary Disorders Center and director of the Facial Pain and Adult Hydrocephalus Centers at Pacific Neuroscience Institute. Thanks for coming along.
Thank you.
Thanks for being here. Yeah, pleasure. So, tell me, at what age did you figure out you were going to be a neurosurgeon?
Yeah, it was an interesting journey. I knew I wanted to be a doctor when I was young. We had a number of doctors in the family, and they influenced me significantly. But I never thought I wanted to be a surgeon. Frankly, I thought, based on what I saw on TV shows, I thought surgeons were kind of not the nicest people and hard to get around. They didn't have good relations with their patients, et cetera, et cetera. So it took a while to warm up to the idea. It wasn't until I went to University of Michigan for medical school, and I was convinced that I was going to be a cardiologist at the time. And I spent some time in a cardiology clinic and realized that just wasn't for me. And then I spent some time in the OR looking at different subspecialties. I noticed that I started to like the brain a lot. I loved how the brain circuitry worked. I loved the anatomy. I loved the different disease processes that patients dealt with and how challenging it was to even diagnose some of these diseases. And that really attracted me. So I was looking at neurology, and somebody said, hey, why don't you go watch this guy operate on the brain? I said, okay. I went to Greg Thompson's OR, and he's a world-renowned vascular surgeon, but at the time he was doing a basic trauma case. And so the brain was laid out. It was this glistening brain, and it was pulsating, and it was just beautiful. And I saw that for the first time, and I was hooked. And I said, this is what I want to do.
Fantastic.
And I took a year additional to my medical school to do a little bit of research and make sure that this was the right decision for me, advance my knowledge in neuroanatomy and some of the other aspects of neurosurgery. And I realized that absolutely this is the way I wanted to go. And then, of course, after that, I went to UCLA for neurosurgery residency. And that affirmed my decision, not only in the field, but also to subspecialize in endoscopic and keyhole surgery, which is what we do here primarily.
Right. Yeah. So med school was always in the cards, it sounds like.
It was.
And because who in the family?
My dad's oldest brother is a physician. He's since passed.
Okay.
He was a family practice doctor, and he actually trained in Iran, had a practice in Iran, and recognized in the 50s that things were probably not going to work out long term. And so decided to come to the United States, was on his way to California for a attending position, and stopped in Michigan because he knew somebody there. And they said, oh, go talk to this guy. He may have a job for you. And he met this guy and got a job on the spot. This was back when there was no background checks or any of that stuff. And he was offered a job, started work the next day, and stayed there ever since. And then his son became a ENT and plastic surgeon. And he was the one who told me things about reconstructing jaws and ears and things like that, which was really amazing. And those were the two medical influences we had on the medicine side in our family.
And so that turned you on to this whole profession. Okay.
Exactly.
And so you also have a sister.
I do have a sister.
Who happens to work with you here.
Yes, she's the smarter one of us two. And so if you look at our whole lives, she's been the smarter one. She's been the better behaved one. So you can ask my mom about that. And her scores, everything has been better. And of course, she ended up at Harvard for her neurology training and did her movement disorder fellowship. And somehow the stars aligned, and we ended up back in LA together. And not only that, we ended up at the same institute together. And she does movement disorder neurology, and we have some overlap with our patients. And it's just amazing to be able to work side by side with my sister, which, if you asked my mom 20 years ago, she would have never thought this was even a remote possibility.
Because she knew both of you.
There was a lot of sibling rivalry going on at the time. Yeah.
Well, she has to be the proudest mother in the world.
She's happy.
Yeah. Okay, so tell me about your practice.
It's great practice. Love my practice. I have a number of different hats that I wear. So I work with Dan Kelly and Chester Griffiths and Howard Kraus in the Brain Tumor and Pituitary Disorder Center. I'm also the director of the Facial Pain Center, which is where we take care of patients with trigeminal neuralgia and hemifacial spasm. And I also take care of patients with adult hydrocephalus. And that's the clinical side of things. On top of that, I am the director of the anatomy lab that we have here. And we train our fellows and we do anatomical research. And I work with an amazing lab director and illustrator, Josh Emerson. And we're doing a lot of great things, trying to change the way we learn anatomy in the 21st century.
We talked a little bit about that earlier with someone. The anatomy lab is you're working with cadavers.
That's correct.
Right? And you're training and learning how things are put together with cadavers so you can do it.
Yes.
Yeah.
So there's a number of different uses for the anatomy lab. I would think the most practical use is for us surgeons. Say we're doing a procedure that we want to get a little bit more experience with, or we haven't done in a while, or we want to learn a little nuance of that. We can go in and do a practice run in the lab, know exactly what we're going to encounter, and then, of course, do a good job on the patient afterwards. But more commonly, what we have are fellows that either they're clinical fellow that we train every year here, or visiting fellows from all over the world that come in and they spend time with us in the lab and they learn these techniques. They watch in the operating room and they practice them in the lab, and then they go back to where they came from and they apply that to their practice.
Fantastic. Yeah. So that's a wonderful resource.
Oh, it's a great resource, and it's open for our colleagues in the hospital system at the John Wayne Cancer Institute. It's really a great resource.
And now you work with Dr. Kelly on pituitary.
Correct, and brain tumors. So I did my fellowship with Ed Laws at Brigham and Women's Hospital in Boston, and that's where I really polished my skills on endoscopic endonasal surgery. And we've learned to expand that here through what we call keyhole surgery, where we operate either through the eyebrow or behind the ear or through other small openings, where we can take out large tumors through small openings.
And that means you're disturbing less anatomy.
There's less soft tissue damage. There's less collateral damage. We think, and of course, a smaller scar, which has a little bit of its cosmetic benefit, but really the goal is to minimize the amount of brain that's disturbed. And the less brain that's disturbed, there's less that can go wrong.
Sure.
Yeah.
And I hear you're sending people home a day after.
Yeah, patients typically go home 1 to 2 days after surgery, after most brain tumor operations and most pituitary operations.
That's extraordinary.
Yeah.
I mean, think about this, 20 years ago? I mean, how long ago? People were...
10, 15 years ago, it was typical to keep a patient 7 to 10 days in the hospital.
7 to 10 days.
Especially for pituitaries, we would have a whole protocol to monitor their electrolytes, and now we've gotten it down. We have a good algorithm, and they can go home and take care of all of that afterwards.
I'm sorry, monitor electrolytes because the gland, to see if the gland is working properly and
there's some
regulating all of the...
There's some hormones that can be transiently altered after surgery, and it can cause some unusual changes in salt levels and water balance levels, and those are things that we keep an eye on. Now
transiently meaning it's just for a little while.
Just for a little while.
And you just need to make sure this is come and gone.
Correct.
Before
they can go back to exactly.
Okay.
Before they.
But now you say you have algorithms.
Yes, we have algorithms that we tell patients. Well, first of all, we counsel about these types of situations beforehand so that they know what to expect. And then in the hospital, we have our nursing staff is well trained to understand the nuances of these particular patients, which are different from other types of brain tumor patients, as to what we're monitoring and what things can go wrong. And then when they leave the hospital, they know what to monitor. And then we have them come back in for some lab tests as an outpatient. And if they follow the protocol the way we've assigned them, they typically stay out of trouble.
We talked a lot with Dr. Kelly about the transnasal work on the pituitary, and I wanted to talk to you about facial pain.
Yes.
Which is something I've just learned about. Trigeminal neuralgia.
Trigeminal neuralgia.
Which has the unfortunate reputation as being the suicide disease?
Suicide disease, yeah.
Seriously.
Yeah.
So tell me why they call it that.
So the best analogy I can give to someone who's never experienced this is imagine having tooth pain so bad that you need a root canal constantly for years. And any sort of procedure hasn't been able to help these patients. And there are a number of causes for this, the most common of which, outside of dental pathology, the most common of which is a blood vessel pushing on the nerve in the brain. So we figured out through, of course, many people's experiences years before, we've figured out how to move these vessels away from the nerve so that it doesn't constantly rub up against the nerve and pulsate against the nerve, and basically causes the nerve to become raw and it short circuits. And then the slightest sensation comes back as pain. And so when we decompress them, they tend to get better pretty well.
Where is this nerve?
It's we access it behind the ear. It's a few inches in behind the ear at the center of the brain by the brainstem.
There's a nerve by the brainstem.
Correct.
That has pressure put on it.
Correct.
That causes pain where in your face?
The entire distribution of the face. Usually it happens in the jaw and in the cheek, but it can affect the entire, from the top of the head down to the jaw.
Why trigeminal? What does that mean?
It's a trigeminal nerve. The trigeminal nerve is a known nerve.
Okay.
And it's called trigeminal because it has 3 branches.
Okay.
So the forehead, the cheek, and the jaw. And so that's where that nerve came from. It's, from ancient times.
Okay.
And trigeminal neuralgia basically means that nerve is in pain. I mean, there are other causes too. People who have multiple sclerosis can get this. People who have certain types of brain tumors in that region can get this.
Okay.
And other types of etiologies. But the most common ones are the blood vessels pushing on the nerves.
What causes the blood vessel to push on the nerve?
We're not sure. We're not sure what causes it, and we're not sure why some people who have blood vessels on nerves don't have pain and others do have pain. But we think it's just from gravity over time, the vessels tend to sag down, and it's the point of least resistance until it hits the nerve, and then it just doesn't move any further.
That's kind of a floor.
Kind of, yeah.
So what age?
We've seen patients ranging from their 30s up to their 80s with this condition.
30s?
Yeah.
Oh my gosh. And it's just horrible. Is this nerve somehow more sensitive than others? Or what gives this incredibly...
nerve... Yeah, it's an important question. This nerve is primarily a sensory nerve. It is the sensory nerve of the head. There are other nerves that do some sensation, but this is the main one. And so if this is affected, their entire face can be affected. And there are other nerves that can cause pain. There's also, for example, the glossopharyngeal nerve that causes glossopharyngeal neuralgia. Much more rare. It's a smaller nerve. And but again, the mechanism is the same.
Where's that?
Right next to the trigeminal nerve.
Okay, so you're still talking about
the same vicinity.
Face, head.
But the trigeminal nerve is the main one that we see. And there are a lot of different ways of treating this. So we have developed with our team a 360-degree approach to our patients, which includes things like basic medical management. A lot of this pain can be managed with just medication alone. Like Tegretol or Trileptal, or there's a whole slew of drugs that are options for this.
Neurontin?
Neurontin's one of them. Okay. Cymbalta, Lyrica.
So
we have a menu.
So you try options. These.
Yeah. If patients don't respond well or have a treatable tumor, for example, would be easy to deal with. But if they don't respond well to these medications, then we go down to the more invasive strategies. And it depends. It's very patient specific. And we engage the patient into what type of treatment they want. Okay. And so it could be a surgery to move the vessel away from the nerve. If there is no vessel, or if they're not a good candidate for surgery, they may do well with something called stereotactic radiosurgery, where we target the nerve with high energy x-rays, no knives. This is all done as an outpatient, but we can target the nerve and say, this is the nerve. We hit it with high energy x-rays from all different directions, and that nerve gets stunned, and that patient's pain goes away after a few weeks.
Interesting.
And then the third option is to go through the cheek and do what's called a rhizotomy. We go through the cheek and we go right to where the nerve is coming out from the skull base, and we deliberately damage the nerve. And as a result, the pain fibers are affected more than the sensory fibers, and their pain gets better.
So you can damage the pain fibers without damaging the sensory fibers?
They're more sensitive, yes.
Okay, to
damage.
The pain fibers are.
Correct.
Okay, so you can selectively sort of turn those off.
It's a spectrum, yes, but we can do that.
After that, does it come down to surgery to go lift that?
So at some people, we would, if they fail medical management, may go straight to surgery because that's probably the best option for them. It has the best durability and the best chance of success. In other patients where maybe that etiology isn't there, then we may want to go a different route. So everybody gets a different algorithm to their pain to be treated. And we use different types of information to assess this. So of course, we have a neurologist in our clinic to help us evaluate our patients.
Of course,
That goes without saying. and to make sure that the diagnosis is correct. Because if you have the wrong diagnosis, you can do the surgery and the patient won't get better. So that's the whole idea about that. And second is we get high level imaging where we're looking at the nerves and the blood vessels and to see if truly is there a vessel in contact or there may be some other etiology that we have to find. So we do that all up front. We get a very good history from the patient, make sure it isn't something else like a viral infection or a post-traumatic type of a pain. And then we apply these different treatment options to them.
What's the scale we're dealing with here? When you describe the trigeminal nerve and you describe the vessel, how big are these things?
The trigeminal nerve is maybe 0.5 centimeter in the thickest dimension.
It's that thick.
So about as thick as the tip of my finger, and it runs along from the brainstem to the bone, through the bone, and it branches out in the face.
I mean, that's a good sized.
That's the largest or second largest nerve that we have coming from the brainstem to the bones in the face.
Wow. Okay.
Yeah.
And now, what about the vessel that is interfering with this?
The vessel is only a few millimeters in diameter.
Oh, that's enough.
In some cases, it could be bigger depending
Yeah.
on their pathology, but usually it's 2 or 3 millimeters in diameter. But it's not the size that matters here. It's really the fact that you have a vessel that's pulsating and rubbing up against the nerve as it's coming off the brainstem. In that area, which isn't well coated by the Schwann cells, the cells that help the axons work, that's the area that short circuits. That's the area that doesn't fire well.
Okay. So you exhaust all that.
Right.
When you go in, when you have to do a surgery, what do you do?
So if we have to do surgery, we make a small incision behind the hairline. We make a hole about the size of a nickel through the bone.
You can't somehow. You can't really sneak up through the base of the skull to do anything, can you?
Well, not right now. We're working on some technology for that. But right now, we still have to get our camera system in there, and we have to let the brain relax a little bit so that we can get to the crux of the problem.
Is it do you use gravity?
Use gravity.
Yeah, I've heard about that.
Let the brain fall down.
Yeah.
And then we cover the brain with some protective gauze. And then we come down and we identify the nerve and the blood vessels. And with some instruments, some keyhole instruments, we're able to elevate the vessel away from the nerve. And then we bring in the endoscope, the same endoscope we use for our pituitary surgery, we bring in through this approach. And we look above and below the nerve, make sure that we're not missing a second vessel or some other etiology that could be causing compression. So we have a 360-degree decompression of the nerve along its entire course. And then we put a little gauze of Teflon in between the vessel and the nerve. Teflon is inert, so it shouldn't really cause too much scarring. And then we close things back up.
You put the Teflon in between the nerve and the vessel.
Correct.
Like a little shield or a little...
Like a little shield. So it doesn't pulsate up against the nerve, it's up against the...
How big is this piece of Teflon?
1/4 inch.
1/4 inch?
Yeah.
And do you stitch it in there?
No.
Nope.
It just gets sandwiched in there.
And it stays?
And it stays.
No kidding?
Yeah.
Shake your head around?
Yeah, don't go too vigorous right after surgery.
Don't go out and play, say, football or like...
Yeah, probably for a few weeks.
Okay,
yeah.
All right.
And,
so
then then it gets stuck together and it won't move.
Oh, it does?
Move. Yeah.
Okay. So then okay.
Yeah.
So how long does that surgery take?
The actual surgery where we go from cut to close is about 2.5 to 3 hours. But there is a lot of setup.
Okay.
Of course, the patient has to be asleep. We have to position the patient, but we also monitor the nerves, including the nerve for hearing and the nerve for the face and the trigeminal nerve. All of that is being monitored by our electrophysiologist so that we are safe and we're not damaging the other structures in the area.
They're monitoring that by monitoring the electrical signals in those other nerves.
Correct.
To say, okay, we're not messing these up by touching them in any way, or...
Correct.
Okay.
Yes. Yeah.
Because again, like the transnasal pituitary surgery, you're in a sort of a high traffic area.
It's high price real estate. A couple millimeters the wrong direction,
Yeah.
you could cause some major problems. So we are very attentive of that. And we do everything we can to monitor and minimize the chance of any new neurological problem.
Yes. So compared to the knee surgery I had last week for my meniscus, this is like...
We have just smaller tools, more fine tools.
Yeah, I wasn't worrying them about hitting my brainstem down there.
It'll be a reach.
Yeah, it'll be a reach.
Yeah.
Okay.
Yeah.
So then what happens when this patient wakes up?
So it varies. Most patients, if we have the diagnosis right and we have a good decompression, they wake up and their pain is gone.
Seriously?
Seriously.
When they wake up.
When they wake up. Now, there are some patients that may have some pain, and we do have patients that get better gradually over time.
Okay.
And of course, they've been on medication, so we have to wean them off the medications over time.
They've been on medication because you tried that route.
Mm-hmm. They're almost always on some type of medication before surgery.
So have you seen people who wake up from surgery and they're pain-free for the first time, and how long?
Usually, the typical time period before a patient has surgery is about 3 years.
3 years of living with this pain.
You have to remember that not everybody thinks of trigeminal neuralgia. So people are thinking,
Right,
I
have
dental pathology. Yeah. Many of these patients have multiple root canals or teeth extracted.
Is because they think this is dental.
They think this is dental. Or they think
their doctor thinks it's dental.
It's TMJ or some other etiology, and they which is appropriate to rule out.
Sure.
But after you rule it out, I think then you have to start to think about the less common but still significant situations like trigeminal neuralgia.
Wow.
Yeah.
So people have been living with this intense pain, like pain you've never even felt before.
Yeah.
For that long.
For years.
And they're trying drugs. I can't imagine that.
That's tough. The good thing is the drugs work. They do have side effects.
Yeah.
And so most patients come to me and they're on some level of drug and they say, I can't function anymore. I can't think as straight. I lose my balance. I want to get off these drugs. And so that's usually one of the main reasons we operate on these patients.
I see. So they've had some relief, but the side effects are becoming too...
Yes.
Yeah. Is this a situation where would you ever prescribe like opioids for this?
So people sometimes come to us on opioids, but the opioids just don't work well for this type of pain. It doesn't really work at the etiology of the pain. So you throw a ton of opioids, you get a little bit of pain relief, but you throw the right drug at it and you get a lot of pain relief.
How many people come to you with this?
So we have a full clinic for facial pain, and I would say we screen a lot of patients. Some of them have true dental pathology or TMJ, and we send them to the right people to get treated. So I would say probably 1 in 10 patient actually really has true trigeminal neuralgia or its variants that we can treat safely.
1 in 10 that you see
through our doors.
Okay.
And then of those, not everybody needs surgery. So a large minority needs surgery. But we determine who needs surgery, who needs some of these other techniques. Sometimes it doesn't work or the pain comes back and we have to have a backup option for these patients. Mm-hmm. So those are where we have the radiosurgery as an option or through the cheek rhizotomy operations, percutaneous rhizotomy operations.
Okay, so you've got tools.
We have tools. We have very good tools.
And sounds like you're getting good outcomes.
Our outcomes are quite good. I would say for people who have true trigeminal neuralgia, 80 to 90% of them, we can get their pain under control or pain-free completely.
That's amazing.
Yeah.
Do you get referrals from worldwide on this now, or where?
We're getting referrals nationally now. We're starting to get more patients coming in from out of the city and out of state. It varies as to how they come to us. So it depends on who's making the diagnosis, if it's a neurologist or a dentist or their family practice doctor. Mm-hmm. But even they find us on the web. Everything's on the web now, and our website, they find us and they want something different approach, or maybe they've tried something and they want a second or third opinion and they come to us for that. The other thing that we take care of in our practice, which the treatment overlaps with how we treat trigeminal neuralgia with this endoscope-assisted decompression of the nerve, is a condition called hemifacial spasm. This is where this is governed by a different nerve, the facial nerve, not the trigeminal nerve. And these are the muscles of facial expression, the muscles that make you smile and raise your eyebrows up and a bunch of other things. This nerve can be irritated by a vessel and it can go into spasm. And then some people can be tonic and they have an asymmetric face. And
tonic?
Meaning that it's stuck in a particular position.
Okay.
Or they have constant spasms. And people who have a lot of interface with other people in their livelihood, so salesmen, TV personalities, musicians, things like that, they are very affected by this type of condition. So there's some medical options. Some medications, they don't work very well. Botox tends to work quite well to stop the spasms, except you are left with an asymmetry in the face because you're basically paralyzing half the face or partially paralyzing half the face. But when we do see patients who have a blood vessel pushing on that nerve, we can go in the same way for trigeminal neuralgia and decompress the facial nerve, which is a little bit deeper in that area. And we're able to decompress that nerve. And again, similar outcomes when we do. 95% of our patients tend to have their spasms improve or go away completely right after surgery or after some period of time after surgery.
That's amazing. Now, is this the same? You're doing
same opening through behind the ear. We would go in, we bring in the endoscope, we look around the corners, and we decompress the nerve with the same Teflon.
In all brain surgeries, when you do what do you call it?
Craniotomy.
Craniotomy, yeah, thank you.
Sure.
Do you take the piece of bone and put it back in there?
It varies. It depends on the size. So our openings now are pretty small. Nowadays, it's about the size of a nickel. So we sometimes will just remove the bone because by the time we drill it out and we had everything, there's not much bone left to put back on. So we just put a titanium plate over the opening. If it were a bigger opening, we would use the bone as well as titanium to put it back together. But the plate works quite well for the small openings.
Then you're fine.
And these plates are diamagnetic, so they don't set off the metal detectors. You go through airports without any problems. You can have MRIs without any problems. They do fine.
So
common question.
How many surgeries? Yeah, is it? Oh, good. I'm glad.
Yeah.
How many surgeries are you doing a week?
It varies between 5 and 8 operations a week, give or take. Yeah.
How do you sort of stay in shape for this?
It's an endurance trial.
Yeah.
So I used to run marathons, and I still run 5Ks, and I think you have to be an endurance person.
You do.
So I run a lot, and I do a lot of aerobic activity, a lot of cardio, and I think that helps. But also good healthy diet and a mindfulness and a well mind works well with this.
Yeah. Do you meditate?
I don't meditate, but I like to think I can relax and take my mind off work with other activities.
Sure.
Yeah.
But you have to be mindful of it sounds like you have to take care of yourself in order to do this. Because you have to be prepared I imagine, for a surgery that could go, just one surgery could go for hours, right?
Could, yeah. Some of these tumor operations can go 12, 14, 16 hours.
Are you serious?
Yeah. The typical operation is
Are you standing there that long?
Or sitting. We have a chair.
Okay.
Kind of like a console with the arm rests and a microscope in front of us. So it's a little bit more ergonomic than standing up and having your head down.
Oof.
But still, it can be taxing and it can draw on you and wear on you.
Oh, certainly. What sorts of things take that long?
Usually the longer operations are tough brain tumors that are wrapped around nerves and blood vessels or in deep areas, and we have to get through a lot to even get to the tumor.
I see. And do you generally know that you're looking at that length of time when you're
pretty
from
much
the imaging?
We can predict? Yes, pretty much we can predict. Yeah, we have a good ballpark estimate of how long it should take.
So you're going to be in there and you're prepared.
Yes, but we're used to long operations, so if an operation goes another hour or two, it doesn't really faze us. In any operation, it's much like flying a plane. The takeoff and the landing in a flight are the critical parts of the plane. That long stretch in between, you can do a lot of stuff without too much challenges. In surgery, it's the other way around. The opening and the closing are the easier parts. Just starting the operation, doing the craniotomy, putting it back together. Those are somewhat routine, and they're the same movements each time. It's when you're in the brain, you're around the structures, around the vessels and the nerves. That's where you really need to be concentrating, and so that's where we learn to pay more attention and be more focused and be more vigilant at the high critical times rather than when we're doing our routine exposures.
Sure. That's like Pele used to say when he played soccer, he knew how high to jump when.
Exactly.
Right? If you had to choose, what is the most sort of satisfying kind of surgery that you do?
Oh, there's many. I would say any operation where we reach our goals.
Yeah.
So when I see a trigeminal neuralgia operation, the patient wakes up and they're pain-free. That's the most satisfying
That's
operation.
That's got to be amazing.
Or if we are going after a tumor and the tumor comes out nicely and everything goes smoothly, that's a very satisfying operation.
Yeah. Does the tumor come out in pieces? And
depends on the type of tumor. For most skull-based tumors, we have to break them down because we're operating through small apertures. Even if it's a bigger opening, it's a small aperture deep down. We have to get them small enough so that we can take them out safely.
I watched a prostatectomy once, and this makes that sound like, I thought dealing with what are the nerves down around the prostate?
The pudendal nerves.
Yeah, I thought preserving those was an art.
Yeah.
But what you're doing is
It's
like
it's
this times
similar.
10.
It's
Is it?
similar. You have to identify. You have to know where
nerve
they are and protect them
Yeah.
and monitor them. All that same concepts.
Well, when they finished this open surgery, they literally, I watched the surgeon. He took a bucket of water or a pitcher of water and dumped it in the cavity.
Mm-hmm.
And I said, "What are they doing?" He said, "Well, cancer cells hate water."
Yeah.
And they were bursting all these cancer cells. Did you do anything like that?
So we try not to use water on the brain because the brain is a lot more sensitive.
Sure.
In some cases, we do use hydrogen peroxide. That is also cytotoxic, so it can kill cancer cells, and it also helps with hemostasis, and it kills bacteria as well. So it serves multiple purposes. But you can't do that at the brainstem. You can't do that in critically eloquent areas of the brain where that type of chemical can damage the nerves there. But other parts, like inside a tumor cavity or a hematoma cavity, that can be done safely.
Oh, fantastic.
Yeah.
Wow. All right. Well, this has been a pleasure. I've learned a lot today, and I think people who listen to this podcast will learn a lot too.
Thank you.
Thank you for joining us,
having me.
Dr. Barkadarian.
Appreciate
Thank you.
it. Thanks a lot.